So I'm Elly Vaughan, I'm a principal at Economist Impact, and I'm here to talk to you today about connecting the comprehensive obesity care, connecting the dots across fragmented health systems. So we've got a short presentation at the start here where I'll talk you through the Obesity Response Index that Economist Impact has been working on. And then we've got a fantastic panel who I'll welcome up onto the stage for a conversation. I will be calling on you for questions, so please, as the panel are talking, as I'm going through the presentation, if anything comes up that you can think of, please do have those questions ready because I will be calling upon all of you. So, the Obesity Response Index. This is an editorially independent piece of work that Economist Impact has been working on, sponsored by Eli Lilly. And what we're trying to do with this index is to look at how different countries around the world, so 20 countries around the world, and all 50 US states are responding to the challenge of obesity through various different policy mechanisms. So it's part of a broader program. So events like this are part of the program. So this is a really important thing, actually. So we have the index. You can see there on the screen, there's some data from the upcoming global index, there's our report, and there's the US index screenshot there as well. But these kind of events are really important because this is how we keep the conversation going, because it's not just about finding out where the gaps are, it's also then about having conversations about how we fill those gaps and how we turn what we find and our insights into actual action. And then another important aspect of this program has been the film series that we've put together, Living with Obesity, Stories Behind the Statistics. And the screenshots are at the bottom of the screen there. I would encourage you to go and have a look at those on the Programme Hub. We've got QR codes for you to go and have a look at that, because this is a really important aspect. So the statistics along the left, I'm not going to read through to you, because I think by all of you being here today, that signals to me that you do understand the scale of the challenge around obesity and that there's a need for action on it. But these stories are really about telling the human stories. So we're not talking trillions, we're not talking billions. We're talking about Lorenzo, who is a family man from Atlanta, Georgia, who has lived with obesity all his life, and talking about his story, not purely defined by his obesity, but talking about some of the struggles he's faced and the stigma that he's faced. And he's one of 5 people that we've profiled in this video series, so I would encourage you to go and have a look at that. But from this slide, what I'd really like you to take away is that obesity is a truly global issue. So the recent UNICEF report highlighted that rates of rising fastest in low and middle income countries. So this really is a global imperative here. But also those highlighted words, it has health, economic, and also social impacts. So this, again, is another reason for action. But despite this, despite all of these reasons for action, we see that no country is on track to meet the WHO's 2030 targets. So why is that? And that's one of the things we're here to discuss today. So the index, what the index does is to assess 20 countries globally and all 50 US states. And what we do here is we assess them based on the policies that they have in place, publicly available policies that they have in place. And then we create a 1 to 100 standardized score, which enables us to rank them, so we can see how individual countries do compared to each other. So I won't read out all of the countries, you can see them there, but we try to be globally representative as much as possible within a sample of 20. So we tried to get different income levels, different regions represented, but as I said, this is a global challenge, so all of these countries already have fairly high rates of obesity prevalence. Out of 100, the average score was 56. That's not very good, is it? So that really tells you that there is a need for action. So even the leading countries that we were looking at still have a ways to go. And you can see that we've got 4 pillars within the index. So these are the broad categories that we've used to sort of divide up the indicators. And the indicators are questions the answers to which translate into a numerical score, and that's how we get to that score out of 100. So really what I'd like you to take away from here is there's a lot of work still to be done, but through the index, what we've hoped to do is to highlight where the gaps are, but then also help countries to see how others are doing. So they can see, okay, I've got a gap here, but actually this other country is doing quite well. So maybe I could pick up the phone to that person, speak to them and see how they've been able to implement this particular policy. So I'll move on to the world's busiest slide. I do apologise for that. I've forgotten all my rules of PowerPoint here, so I do apologise. But the first point here is that most countries lack a comprehensive obesity strategy. So 13 of the countries we looked at had an obesity strategy. But why do I say they lack a comprehensive one? Because most of them don't have measurable targets. How can we know if something is successful, if something is working, if we have no means with which to evaluate it? This is why we need measurable targets. They also did not have broad stakeholder engagement. So obesity is an all-of-society problem. You can't solve it in one sector alone. But also, critically, you need the experiences of people who are living with obesity. And only Brazil actually included them in their policy development. And finally, only 3 countries included any specific funding for the implementation of their plans. And again, if we're thinking about how you turn a plan into action, one of the critical factors, let's face it, is money. So without that funding, those plans may not be translated into the action that we need to see. Obesity-related stigma remains widespread. Sadly, I think a lot of you in the audience may not be surprised to hear that. But there were only 5 countries in our 20 who actually acknowledged stigma in their obesity strategies, and even fewer actually had any concrete actions to address it. And only 6 of them had any kind of legal protections around weight discrimination. Coverage for comprehensive evidence-based obesity care also remains fragmented. So only one country, the UK, covered all 4 of the main classes of obesity care that we were looking at here. So those were nutrition counselling, intensive behavioural therapy, obesity medications, and metabolic and bariatric surgery. Only 1 out of 20. 7 covered 3 forms of care, 3 countries covered 2, and 3 countries only covered 1. So again, going back to those people I was talking about in the sort of earlier slides in the videos that we've profiled, that means that these are people living with a disease that they can't get access to evidence-based treatments for. And although we saw some good clinical guidelines, clinical care pathways, etc., fundamentally, if people don't have access to those treatments, then those clinical guidelines may not actually be very effective in practice. And then in terms of thinking about healthier eating, these tools are actually being very under-leveraged at the moment. So various countries had limitations and restrictions around advertising of food, particularly to food and drink to children, but only 8 of the countries that had any kind of laws around that actually made those mandatory. So again, you're leaving those voluntary up to sort of individual retailers and manufacturers, etc. So few countries had clear front-of-pack labelling, which is a WHO best buy and is known to be very effective in terms of helping to influence people's choices when they're sort of in supermarkets and things like that, but also menu nutrition information was very lacking as well. And excise taxes on food and drinks that are considered unhealthy were also underutilised as a way to help to support behaviour change, with only Mexico actually implementing both of those. And then if we think about active living, this is not about exercise, this is about encouraging and facilitating, critically, people to have more physical activity in their daily life. So access to safe spaces for walking, for cycling, active transport, reducing car usage. Again, we saw that there was only 6 countries that were actually implementing sort of comprehensive plans around that. So this just gives you a bit more idea of how that 56 out of 100 comes about. So there is some great stuff happening, but really the story is of fragmentation and inconsistency between countries, but also within countries. Some do really well in one aspect and really poorly in another. So I would encourage you to delve into the findings to learn a little bit more about what we found in the index. So this is, again, another nightmare slide, but this is just to say that we had a lot of people who we engaged throughout the process. So when we were coming up with the index framework, and then when we were actually finding our results, we talked to a lot of people in the countries that we were looking at in order to find out from them, are we, in the index, are we looking at the right aspects? Are we asking the right questions? And then once we had our results, have we sort of got the right information? Are there other sources we should be looking at, etc.? So this is just to highlight and to thank all of those people who gave very generously of their time. So that's it from me. I will be around afterwards if you have any questions. During Q&A, you can also ask questions, but I will move us on to our panel because we've got a great panel of people to talk here today, and I think you'll be much interested to hear what they have to say. So I'll welcome to the stage first Jens Christian, who is founder and head of the Children's Obesity Clinic at Holbaek University Hospital. Guilherme Duarte, who is executive director of Unite Parliamentarians Network for Global Health. Andreas Herdt, who is the co-chair of the Obesity Surgery Self-Help Group in Germany. And then Cristiana Caldarelli, who is International Therapeutic Area Lead at Obesity at Lilly. Right, thank you everyone for joining me on stage. So, we talked a lot already about the need for integrated care, and what I really want to get into the discussion today is not just the policy aspects of it, but also then sort of talking about what that then feels like on the ground for people living with the disease. And critically, this is about, for any health system nerds out there, this is about integrated care that's vertical and horizontal, but also just pleasant care as well. So care that doesn't feel stigmatizing and feels like your obesity is being recognized as a disease, and very important aspects like this. But obviously the index does look mainly at policy. So I wanted to come to you first, Guilherme. So you've worked a lot with policymakers and politicians in the organization that you helped to run at Unite. And why do you think obesity care has been so fragmented? And what do you think it would take for governments to approach it as a disease that links through to other non-communicable diseases?
Yeah. Good morning. Thank you so much for having me. So I think it's like a lot of questions today, a lot of issues. I think it's a matter of focus. I think it's a very chaotic, a very volatile world environment. So I think that obesity will slip through the cracks like anything else on the health system. So I think there's a lot of noise. Policymakers are flooded with priorities, competing priorities, and obesity actually suffers from something additional, which is because it's something so common. I think it's a bit seen as a lifestyle issue, something that the person must take care of himself, of herself, of himself, and so it's not seen as really a disease. I mean, I don't want to bring the boogeyman again into the room, but in COVID we've seen what obesity can do to infectious disease, and we've known the impacts all along. So. So it's not a matter of understanding. I think it's a matter of probably lack of focus, lack of will, perhaps, I would say.
Yeah, so it's that they're not sort of taking on board the fact that this is a serious issue that requires...
Yeah, absolutely. And you see that also, for example, with healthcare professionals. I mean, even a medical doctor, which I am trained as well, but you've seen it as something that you realize that lifestyle can take care of. So you delay every other intervention, including community interventions, to just last minute, and you tends to think that you don't need to do them until, well, that actually the person must take care of themselves.
Yeah, and Jens Christian, I wanted to bring you in here because obviously you've pioneered and sort of set up this whole integrated care model specifically for childhood obesity, but I think would have a lot of applicability to broader obesity care. So thinking about that fragmentation, what have you done to address that, and how have you managed to create a system that is very person-centered?
Yes, thank you very much also for having me. I think we need to understand what we are up against, and I don't think we are understanding that at all. I think we have 70 years of evidence that what we've been thinking is not working. So I really need to put out forward that obesity is the most complex disease we have ever encountered, and it has thousands of multiple interactions with everything. So the whole thing about obesity in our clinic and in our model is to understand that the body regulates fat mass as energy at any cost. It will defend energy and fat mass at any cost, with every other physiological functions. So we need a holistic 360-degree course around each patient, child, adults, and adults, in order to address everything, not only physical activity and nutrition, but everything. Also, how to raise a child by parents, also how to adults are interacting in working life, everything. And I think that is the main barrier why we're not succeeding, because I totally agree about focus and other things like that, but we're against something what is not working at all, what we've been doing. The rates are soaring. It is totally catastrophic what's going on for the global health perspective. So the whole point of your answer is that we understand that the fat mass is actively defended and taking all precautions in that regard. And those have yielded results that you are aiming at.
And you've also talked about how the sort of genetic drivers of obesity as well. Could you just talk us through sort of very briefly because I think that's a very important point, as Guilherme was saying, that often it is still misunderstood as a lifestyle disease, and we go after these lifestyle interventions, and you've already touched upon some of the biological truths of how the disease operates in the body.
I think this is another, number two, pivotal point, and that is that BMI or fat mass is genetically controlled by 65 to 70%. And that goes into the paradigm shift. Right now, we have a culture where obesity is seen as an individual problem. How can you do that to yourself? Aren't you motivated? These beliefs are totally outdated, belonging to the last century. We need to understand it is genetically driven, and thereby we can actually liberate persons by understanding themselves. It's not their own mistake. It's due to the fact they have some genes that they have no control over receiving, and they need to take care and be aware about that. And then we have various levels of care to try to do that. But we also need you to change the society, to change the understanding of physicians and policymakers to make it more urgent and not just more reports about things. We need to do and do things right now.
Absolutely, absolutely. And Andreas, I wanted to bring you in here as a patient advocate and someone who's worked alongside people living with obesity a lot. How does this fragmentation and obesity care as it is today, how does that feel and how is that experienced by people living with obesity?
I would like to answer that in two ways, because as of now, we talked about fragmentation of the health system as such, but there is a different thing besides the regulated health system. There's the gray market out there. And as long as the regulated system is not really funded and treatment is not reimbursed, the gray market is an option for all the people living with obesity. And as long as every person with obesity hears 20, 30 years that it's its fault, he and she has to take responsibility themselves. And how do they do that? They just seek help in reading books that don't work, working with consultants that are not doctors, self-declared nutritional therapists and stuff like that. So they seek help anywhere, and that needs to go away. So that's the first thing. And if we get rid of the gray market and then talk about the health system itself, or the regulated part, there is the big problem that, as you said, it's not a simple disease. We have so many different factors that go into that. So there is no simple solution. And no single doctor, no single counselor can solve that. So they need to interplay. And if you then put yourself in the shoes of somebody living with obesity, being told for so long that it's their fault, there's already a barrier to seek help in the first place. And then they potentially need to go not only to one doctor, but to 2 or 3, and it has to be coordinated. And if they don't get the help there, if they don't get steered through that system, they most likely give up at one or other time.
Yeah, that navigation is definitely a key aspect. And I think also there is lots of evidence around, obviously, the stigma that people living with obesity face in medical settings, and how that then translates into reluctance to seek care for other conditions as well, because a lot of people fear that they'll go to the doctor about one thing and, well, it's because of your obesity and things like that. So it's a great point. Thank you, Andreas. And then, Chris, I wanted to come to you next, because one of the key things with the index that we've been working on is that we're looking at prevention and management, because these things are intertwined and they should not be seen in opposition. But this is often how they're framed. We've obviously focused a lot on prevention, and that's part of this narrative around blaming the individual, because prevention is something that then you can give responsibility to the individual living with the disease. But from an industry perspective, how do you think that different stakeholders could partner to create sort of the kind of joined up prevention and management services that we're talking about here?
Sure. Well, first of all, I think that you are completely right to think that, in the prevention measures that we see right now, there is a little bit of the stigma that all of my esteemed colleagues here were talking about, right? Guilherme was saying it's people's fault. Dr. Jens Christen was saying, actually, there is a genetic or biological part to it. And obviously, Andreas was sharing the experience of people living with obesity on how they access or they don't access right now the healthcare system. And in the prevention, which of course in most of the cases it's a healthy lifestyle, so it's appropriate nutrition and physical activity, there is a little bit of the concept that if we follow that, then obesity will be prevented. But we know that this is not the case. And we also need to think about obesity being, in its complexity, also the cause of many complications, more than 200. If we think about diabetes, 42% of diabetes is caused worldwide by obesity, 78% of hypertension. So to your point, Elly, we cannot think about only health lifestyle, which is very important and is a super important tool in the management of obesity, but as the answer to this very complex disease. And what we see nowadays, we see some best practices of some health systems on how they can be really tackling obesity. So the first one is actually coming from the European Commission. We are expecting a European cardiovascular health plan that actually includes also diabetes and obesity as part of it, where we start to look at cardiometabolic issues. And I think that the interesting part of this is that it will provide the member states some list of actions and also milestones, to your point. If we don't measure, we don't know if we are progressing and or if we are winning. And it will be actually to the member states and to their health systems. And when I say health system, I mean the system, not just the public one, but all of the stakeholders, the scientific community, the patient group, the advocacy group, to actually help to get the right resources to implement this. Another example, I am very proud of my home country, because just a few weeks ago, they passed a law. It's the first country that passed the first law recognizing obesity as a chronic, relapsing, and progressive disease, and putting together an integrated care pathway for patients living with obesity. And yes, there is an observatory which will collect a little bit more data and report to the Parliament on an annual basis. But there are actually specific actions, again, that the stakeholder community can take. And here we were discussing with Andrea before. So here in Germany, I think that obesity has been recognized as a disease at the beginning of this, around 2020. And last year, there was this law passed for setting up disease management center, which still are not fully executed. So I think that when we talk about policy, to your point, is important to get the recognition of obesity as a disease, to get clear, very practical actions that can be taken, but also making sure that then those ones are executed. And we really hope that this is done in Germany now in 25 and also next year in a swift and fully way, so that patients can really access integrated care. For example, the DMP, the Disease Management Program, foresees combination of different parts of health, like the medical side, the nutritional side, and the psychological side, to get together to really help patients living with obesity being treated appropriately. So I think there is a hope, but we are already late, and we need to move fast.
Yeah, and actually your point about the impact on other diseases is very important, because that's yet another imperative for action, isn't it? Because actually in preventing and managing obesity, you are getting these ripple effects in other disease areas and things. Guilherme, I wanted to come to you next, because we've heard about various different challenges here, and you spoke yourself about the sort of challenge of getting that political will and prioritization. So based on the work you've done both with the Portuguese government but also in the Unite group that you now work with, how do you think we can get politicians to really sort of sit up and take notice of obesity as this pressing issue that they need to take action on?
So I think the index is a start, and I think I really like how it also encompasses some of the issues on prevention, as already it was said. And I don't want to give a step back in terms of the lifestyle, but I think it's also very important to note the pressures and environmental pressures that people are still facing. So obesogenic environment, of course, but I think the index is a very good step also to create this awareness. I think they need very simple work plan, very simple roadmap or what to integrate. I think questions still have to be clarified. For example, it seems that we're advocating for a vertical integration of the health system, or at least focus on, but at the same time recognizing the impact of determinants and how obesity is also impact others. So I'm very curious to see how this cardiovascular health plan will come out with how to address the determinants. And if it's going to be a vertical approach, or it's indeed a more holistic and to all determinants. So that's going to be important to do, because again, and I don't want to overstep again on this point, but policymakers and decision makers will be flooded with competing priorities. And it's not only health system. I mean, we've got the economy, we've got the environment. They'll all fight policies that they see as entering their turf, and this is a truth. So we have to elevate also health in other areas. I mean, the buzzword health in all policies, it makes a lot of sense, but unfortunately in the government you don't follow it. Usually health ministries don't have a lot of power inside the ministries. So all those things, in the end, they will matter for the ability of a health ministry to enact change on their ministry. So I would say that I've seen a lot of good examples. I'm very proud of the work, for example, Portugal has been doing. They've actually constituted a long time ago an interministerial governance structure with the environmental, with the economy, but it's, there were hard gains in terms of what could have been achieved, because the other areas always see some concessions as being losses for their interested constituents, either a food industry or other people in place. So we do have to go slowly, very directed, I think, very focused, and with a clear work plan so that they can enact. Again, decision makers are very short-lived in terms of their political cycle, so they really want to understand how can enact change, if the change will be visible immediately, and if they can advocate that or at least promote it as a win-win for everyone.
Definitely. And we already have the evidence of the best buys, the WHO best buys, about which interventions are effective. And then they did also come out with quick wins, which sort of correlated the best buys against a sort of temporal element to say, well, actually, if you do front of pack labels, you start to see immediate effects and things like that. So I think there is a lot of the evidence there. And Jens Christian, I wanted to come to you next in terms of, you know, the model that you run is very successful. And I know you've sort of shared that variously around the world and within Denmark itself. What do you think are the critical success factors of the model that you run that others could learn from in terms of reducing that fragmentation and making the system work better for people with obesity?
Yeah, that's a very good point. And I think that education is very central. It's not the most important thing, it's just very important. Because when you really, as a physician, but also as a layperson, when you really understand how genetics is ruling the fat mass, how that is not anybody's fault, but that's how it has happened, and you are actually going to be in threat of developing more than 200 complications throughout life, and how that is impacting thriving, physically, mentally, and socially, very, very negatively, then it actually gives itself. So in my point of view, you need to understand the nature of the disease. When you understand type 2 diabetes or type 1 diabetes, something about insulin coming from pancreas, and when it's not coming, you have high sugar and stuff like that. That's a very simple understanding scientifically of a disease. The same thing goes with obesity, just a little bit more complex. So when you understand that the fat mass is actually preserved, then you need to understand you need to do everything in your power to try to change that for each individual child, adolescent, but also adult. We need to come together, and I totally agree with your argument before, that people are defending their own turfs. So when you want to get the obesity paradigm into the specialist education in Denmark as a pediatrician, everybody's fighting to keep on their own territory. So it's nearly impossible to get in there. We should actually have obesity in because it's interacting with all the other specialties. So the whole point, in my point of view, is knowledge, is education, that people understand, healthcare professionals, but also patients themselves, what they're up against. And when they get that understanding, it becomes easier.
And this is why it's so important that obesity is viewed as an NCD and looked at as part of this NCD agenda, because then implicitly you are talking about it in the context of metabolic health, of liver disease, of cardiovascular disease, of all of these other cancers even. You're talking about it in this broader context. So I think that's a really good point. And Andreas, I wanted to come to you next in terms of how does this fragmentation, but also the stigma that we've already touched upon, how does that manifest itself in terms of when people living with obesity are trying to access care, and what concrete changes do you think could be made to improve those day-to-day interactions with health services? Sorry, it was too easy a question. I do apologize.
There's no simple answer to that. But maybe to stigma first. The major issue from my point of view is that people sooner or later start to self-stigmatize because they just believe what they've been told for years and years. So they internalize that and they believe it's their fault. And for that reason, as I said before, they do not seek for help outside of their control. They just believe everything is under their control because they have the illusion it's what I eat, I can control that. And for that reason, they only read a book or something like that. They try, they lose weight, they gain weight. We get those curves, the JoJo. Everybody knows that. At the end, people do not seek help for that reason. So that's one simplistic way to view that part. On the other hand, when then people enter the health system, we see as well stigma within the doctors. So if we don't have a very trained and knowledgeable doctor like you, and most people are not like you, unfortunately, So what they believe, they just believe it's their fault and they can control it. So even the doctors transport that sense of urgency. You need to do something, but it's not I need to help you, it's you need to do something. So they send people home and then they should do something. And last but not least, when you talk about the fragmentation, in Germany, we as of now don't have a gatekeeper function with a general practitioner, so people still can go to whatever professional they like. And unfortunately, so it's kind of random what kind of treatment they get. So if you go to a surgeon, you will most likely get surgery, if it's the right thing to do or not. And if you go to a psychologist, you usually get psychotherapy. And it's only a rare case that a professional say, you're not in the right place, and refers them to a different one. They rather try to apply what they learned. And there's nothing to blame in that, but what's really lacking is somebody that controls the process, tries to figure out what's the reason, what's the cause, what's the right treatment for that person.
Yeah, I just have a brief comment. Thank you very much, Andreas. I think you are so much in the center of this discussion, and I think that you're also expressing, in my point of view, the lack of understanding in the society. When we speak about motivation, then you can ask yourself, who has the treatment responsibility? The patient has. This is not right. This is wrong. Caloric restriction is also a fundamental point of understanding obesity, which is flawed. It is old-fashioned. The point of motivation and caloric restriction is that the arrow is pointing towards the patients. We need to transcend that. We need to understand that it's governed a disease by itself and actually go by that. And that's where you are diminishing or liberating the patients from stigma and discrimination, to really understand it is not their mistake. It is not their fault. And that could do that. And then the other reason you're asking for comprehensive care led by somebody, not just somebody's interest area, which is totally correct, is again coming back to education. What to do with a patient, whatever age is appearing, come to you with obesity, what do we do? And that is not been developed into the societies. This is just very fragmented. Why? Because it hasn't been prioritized to have education for everybody. So it actually goes around this. And there you need to stop that and actually go and actually start educating people, make the society understand what obesity is, not only some singular doctors, but everybody, to understand. It goes in schools, how pupils are bullied due to the fact that the parents and the teachers do not understand what it is. And it's devastating. Sorry.
No. Let me just build on this idea just to create a picture here where, in a world where probably obesity is not a stigma, and follow me because this might go wrong, but then you'd go to someone with clear obesity and ask, are you all right? Because that's what you do with someone with a broken leg or with another disease. Because nowadays, I think the person would be offended. So I think that's a clear picture. But so this turning on the stigma, I think it's very entrenched in the society. And I think that even us would defend ourselves in the sense that, well, I'm not that fat, I'm not that obese, I'm not, So I think it's a very, very needed changing, and there's a very, because you wouldn't imagine this, I think. I wouldn't imagine someone coming to me and say, hey, you got some weight, are you obese, because it's actually this. So, sorry, I was just reflecting on this while we were thinking, and it's actually perhaps a campaign saying, are you all right, or something for, to create this relation of agency. And it's very interesting what you mentioned about the responsibility of treatment, because when you do rounds in emergency, people always come to doctors and say, I've got this, so please treat me. And probably you didn't see that with obesity as well.
Yeah, there are various organisations. I think the World Obesity Federation, Obesity Action Coalition, have sort of toolkits around how to talk to people who are living with obesity about their health, and then also sort of how to approach whether they want to talk about their obesity in this interaction. In particular, because again, people living with obesity don't necessarily want it to be, I've come in to talk about my headache and you're telling me it's because I'm living with obesity. So I think it's that sort of that respectful dialogue that comes from this broader education. But I did want to bring Chris in here as well, because we've heard about a lot of challenges and how we can get sort of different sectors involved and things like that. And coming from the pharma industry, obviously, you're quite used to sort of working in different partnerships and things like that. What sort of things do you think, not just the pharma industry, but other industries and other sectors could do to sort of partner to help to prioritize and get more action on obesity as well?
Sure. Well, just to continue the conversation, education is a key one. And I think that education, we always think about the stigma, and so we're thinking about education for patients, for the bigger society. But how many university courses or medical school courses actually include a curriculum on obesity? To your point about also the ability of the healthcare professionals, so the doctors, the primary care physicians, for example, who are the ones that are usually seeing more often and more frequently all of us, are actually able to understand how to early detect obesity and also how to provide support to manage it effectively. I mean, before we were talking about prevention, and if really if obesity, as we are learning, is actually the cause of so many complications, isn't that management the prevention of all of these other ones? And how can we actually partner? As you said, it's going to probably be industry and the education sector and the scientific community, the patient groups, to actually work together to make sure that we raise the knowledge of obesity. And, I can hardly imagine what it means to go to a doctor and feel stigmatized for a disease that I have. I don't think that we have experienced that in many other places before, maybe in a few. And this is something that we really need to act quickly and swiftly to change. I think on the other side is if we're thinking about progressing science and ensuring that we increase access to obesity management medication is definitely something where we can partner together. And the way I'm thinking about of the science progressing, for the first time, again, October has been a very busy month, but there's been the publication of the first multinational guidelines by the European Association for the Study of Obesity, EASO, which is one of the main scientific community here in Europe, that they identified for the first time, as I was saying, a framework to actually treat patients with obesity management medications according to their type of obesity. So Dr. Jens Christens was saying there are many types, right? And I think that it's very important to start to drive that tailorization of the treatment for patients. And also, moving ahead the conversation from being about excess adipose tissue and weight to actually some of the complications. So before we were talking about 360 degrees, looking at the health of individual, I think this is a very important first step. And we can also work together for early detection. If I'm thinking about, for example, in Greece, they just introduced a comprehensive health check for people that are between 30 and 70. A health check that looks at cholesterol levels, they look at cardiovascular risk, but also obesity and diabetes. Again, this is done by primary care physician. So can you imagine for anybody that is also probably doesn't understand that there is a disease behind what they are experiencing, the ability to go and speak to a primary care physician and starting that health conversation with them, and then probably taking it through an integrated care pathway. So I think that we can, work together on many things, but the one that is very, very important to actually support all of these is also defining evidence-based policies. And this is very important. There is a lot of data. There is a lot of evidence. We have a really good understanding right now of the status quo, but we're also starting to develop more and more science. And I think that we can work together as a stakeholder, the policymakers, the payers, the scientific community, the industry, and above all, I think we need to start to think about policies that are based on the experience of the patients, to also look on how we can drive this access to integrated care. And to Guilherme's point before, I do think that considering the vast cost right now of obesity, that those pathways can also result in better cost containment in the longer term. So many things to do together.
Yeah, you've given us a comprehensive list of tasks to go away with today. But one of the key things you mentioned there was about sort of education, and also I wanted to come to you, Jens Christian, on that, because I know you've done a lot of educating of healthcare professionals around the model that you use. How do you think we can sort of try to share sort of best practices globally a bit more at scale, rather than, you are very impressive, but you are one man. How can we start to sort of get this learning more global?
We need some decision making. I was chair of the European Task Force on the REASA for the last 10 years, so I've been very much in that area, master classes and all that. I was also been training more than 1,000 healthcare professionals within the last 15 years in Denmark and Scandinavia. And the main barrier is actually what I was mentioned before, that is that our healthcare professionals have ideas what obesity is, but it's actually wrong, sorry to say. So when you speak about motivation, nearly all healthcare professionals around the world, not Denmark, around the world, they are very certain about motivation. And it only goes one way: stigmatization and discrimination. The same goes with caloric restriction. The same goes for small steps. There's a lot of paradigms out there that, in my point of view, is wrong. And it's actually compared to the plague in 1543, when everybody thought that the plague was due to the punishment from God. It was an infectious disease. We didn't understand the nature of the disease at that time. And it's very similar to what we're experiencing right now. So I really think that we need to have decision-making in terms of prioritizing obesity, like in Italy, in terms of taking it seriously and not just go there, and then have access to care. People need to ask, please help me, according to the Hippocratic Oath, according to the doctor's wish. You cannot just go there and you should do something. That is totally wrong. You need to respect the consultation process where people ask for help. And when they ask for help, we should have something to help them with. Right now, in most countries, when people are asking for help, there's nothing. So patients are standing there with enormous problems, and they're receiving nearly nothing, which is, in my point of view, actually a breach of human rights. It actually is. In my point of view, it's a breach of human rights that we are having this disease globally affecting this amount of people with these costs economically and personal suffering, and we are actually not being prioritizing it. It is actually absurd.
It's a great point you make in terms of, firstly, there's stigma means that often people don't want to ask for help, and then,
yes,
exactly as you say, if they do ask for help, they don't necessarily have any help that they can be given, and certainly not things that we know actually work. And Chris talked about different sort of policies that we can put in place and things like that. And audience, I will be coming to you in just a moment, so start thinking. Guilherme, I wanted to come to you next in terms of how do we get these policies then into practice? So in the index, I talked about how we've tried to look at sort of proxies for implementation, like measurement, funding, etc. What do you think are some of the key things that, as we're thinking about either building obesity strategy or strengthening what we have, how do we get these into practice, essentially?
So I'd say you have to have a mass of supporters in first place. So either local communities, national opinion makers, and then put it in practice either through parliament, lawmakers, parliamentarians, to run through it, or even directly by the government. So as you know, or at least in most democracies, especially on the north, who passes laws are either governments or parliaments. So those would be the two. Of course, you have to guarantee that you've got allocated budgets. That's the second thing. And parliamentarians also have that role in terms of the defining what the budget is. So I think that's very important. You cannot pass a law that then it cannot be implemented. Of course, the law has to be effective, has to make sense, has to be, and that's the tricky part, I would say, sometimes, because it's you do have to. We don't believe there's one fit-all law, so you do have to adapt it to the community. You do have to see what's your current status that you're departing on. There are countries that are more advanced in terms of that, so you'd have to maybe get some additional gains. There are others that have a lot of work to do, including starting action plans, starting national plans to achieve certain objectives. And then, of course, you'd have to guarantee that this won't fall into the priority of the of the parliaments, so that they can keep oversighting this. They can ask the governments what's the implementation. They can engage the community, also to promote their leadership in terms of these matters. And if you create noise enough, if you still push it, then perhaps in a couple of years you have a nice effect of catalytic actions that drive you where you want to go. And so, of course, this has to be done with leaders, either in clinics or with programs. You have to be based on data. You have to be based. The index can be a nice monitoring tool as well. So all these come together and enact change in a slow time, but I think it's the policy time. I mean, you don't expect to change community in a very fast way, but you have to start somewhere.
And I think actually you've raised a very important point there in terms of the measurement being a tool to also hold government to account, to say, you haven't achieved this, why haven't you achieved this, etc.
Let me just very briefly say that one of the great things, for example, in HIV, how we advanced it was the 1999 target. So you do have to have something to say, hey, we're not doing any progress, and these are very interesting tools to just hold governments accountable.
Definitely. And I'll be coming back to the panelists for a final quick fire, but I do want to open up to the audience as well, if you've got any questions out there. Okay, I've got 2 questions over here. If you can just say your name, where you're from, and then give your question briefly, please.
Yeah. Hello. My name is Mustafa. I'm based in Hamburg, Germany. I'm a public health researcher, and I research the cost effectiveness of digital obesity care tools in Germany. And I was just very happy today that there was a lot of focus, and it was highlighted multiple times, that the burden shouldn't be put on individuals, because even in medical school, we were never really putting that narrative there. And I think it's very difficult for healthcare professionals to have that narrative. But also, on another side, like these public health efforts are not alone. There's a lot of competitors out there, like especially unhealthy food or other unhealthy behavior industries, or even the gray market industries, that they really put a lot of effort into influencing people and the policymakers to put these blames on the individual, because that's where their business model, this is how their business model works. So, and they are much faster and much more effective in working that way, because they put in a lot of money and a lot of time in that. So, how can we really catch up with being able to change these narratives?
It's a contentious issue. So Christian has put his hand up, so I think he's very able to answer.
Thank you very much for the question. I think it's a very important question. We have put forward the vision of the best for the child, the conventional right of the child. Because you really go down that alley, what is the best for the child, the conventional right of the child, it actually answers itself, what you just asked. But you're right about the power and the money and how that is influenced, and that needs decision-making in order to guard the best for the child throughout society, from they're born until they're ending their lives. So I think that is a very strong value. It's a very strong way of communicating and understanding the problems at stake, because this is not just individual financial opportunities. This is public health on a global scale, and we will need to get that and educate and make decisions about that.
Anybody else like to? We've got quite a few questions, so I think we'll move on. Michaela, could we go to the lady in the pink, please?
Thank you. Good morning. I'm Rachel Thompson from the World Obesity Federation. So thank you and congratulations to Economist Impact for your great index. I just wanted to also share that World Obesity is working on another complementary study, which is called it's called MAPS. It's Management and Advocacy for Providers, Patients and Systems. MAPS is better. Where we were actually we're attempting to map the obesity landscape in health systems and across countries more globally. So it's a survey that's open at the moment. There's actually 3 surveys, one for healthcare providers, one for people working in policy and advocacy, and one for people living with obesity. So we've got that survey open right now, and we'll be collating that data next year. But we also are doing deep dives, and so in 6 countries, we're doing qualitative work. We're having policy roundtables, and we're hopefully starting to build national coalitions to start to build those movements with civil society as well. So I just wanted to share that. But I also wanted to just make a comment on the talking about especially how we can get politicians to prioritize. And I think there's something about maybe we need to change the narrative away from individual responsibility, but also we need to change the narrative away from obesity as a cost to an investment. So a lot of what I've been hearing is actually, if we can focus on obesity, embrace all its complexity, what can we achieve by addressing obesity comprehensively across health systems? How will it actually enable collaboration? How will it actually definitely help improve health for all? But yeah, so a question, and just keen for your reflections on this idea that you started with, Elly, of in terms of the insights from your work. It's the key issues: fragmentation and inconsistency. So really thinking about fragmentation also in the context of, we're here today at the World Health Summit, others were in New York. There's so much buzz, actually. There is a lot going on in obesity right now. We've heard about the good stuff in countries in Europe, but how can we, from your different perspectives in your different areas, how can we avoid fragmentation? How, going forward, can we work better together? So just interested to hear any reflections on that. Thank you.
Great question. And I would just say as well that at Economist Impact, we have been working with the World Obesity Federation as well to coordinate our work so that we ourselves are not fragmented and part of that duplication and problem. So would anyone like to tackle Rachel's question in terms of thinking about the momentum and how we can keep the momentum up and build upon it? Christy, do you want to?
Yeah, no, just to start, and then I will leave you the stage. So first of all, also I want to commend the World Obesity Federation, because we were talking before about education, and they have a very clear education program for healthcare professional, which is very well sought after in many countries in the world, not Europe. Today we were focusing a little bit more on the European country. I think that, one of the key things about really design, we need to design the system to have that integrated care. And by designing, I think that we need to really, first of all, make sure that patients, we all know that people living with obesity deserve to have a healthcare that is easy to navigate, that is seamless, that is smooth. And I think that if we start with this principle, which I understand is not usually very common in many places, but is common for some type of diseases, we can make sure that the care pathway for patients are designed on purpose. And to your point, also having some measurement and KPIs to understand, key performance indicator, to understand if what we want to achieve is progressing. And finally, for me, I'm wondering, sorry, I don't recall exactly who was saying it before, but why not designing these policies and integrated pathways with, yes, all of the multi-functional specialties, but also with patients? Because if we think about the patient as the final, if you want, user of those pathways, they know already what good looks like. Mm. Yeah, unfortunately, absolutely. They are the one, yes. We've got a few more questions, and we're running quite short of time, but Jens, please go ahead, yes. Jens,
okay, very quickly. I think your question is a very transcendental one, it's a very large question about inconsistency and fragmentation, and I really think it comes from one place, and it comes from that we are generally, in the Western world and globally, we are thinking reductionistically. We are thinking one solution for one thing. We need to think in an integrated scale. And honestly, I cannot think of one stakeholder not relevant to this discussion. So we need to include everybody. And that is a very huge coordination challenge. But I really think that is the answer to your question.
Absolutely. And we had a question over here as well. If you can just say your name, where you're from, and ask your question quite briefly so we can get to others.
Yes.
Thank you.
So thank you very much. I'm Vijaya Nath. I'm today from Said Business School in Oxford. And actually, I work more globally in the UK on medical leadership. So I guess the thing I wanted to commend you all for is the end of this, that we need to educate the clinicians generally and really empathize with the fact that patients are seen as the issue. My question is, how do you think the access to the new injectables, these magic drugs that certain celebrities and certain people with money are able to access that have been shown, in the last 2 years to help with this issue. Do you see this as part of the solution? And how would you like to address the issue on the cost of this versus where it's needed and the access of these injectables?
Okay, well, I think firstly I would say that certainly from the position of the index, they're part of what we see as comprehensive obesity care that would still be mediated by a healthcare professional making a choice about what the most appropriate and effective treatment is in exactly the same way that you would for any disease. Jens Christian, Andreas, actually, sorry, I'll come to Andreas first, then to you, and Jens Christian, sorry.
I'd just like to put a little bit different perspective instead of just talking about effectiveness of the medication and the cost side. There's another thing. There is medication available, and alone that it is available changed a lot with the physicians in Germany, at least. So now they have a tool, they have another tool. It's a tool that they know, it's a medication. So if there is a medication, it seems to be a disease. So that kind of thinking, that changed a lot for many physicians, and it changed a lot for the patients as well.
That's a great point, Jens.
Yeah, it's a very good point. I've been working with obesity for 30 years, and it's just within the last years we actually can utilize these injectables to patients that are very difficult to treat. But in my point of view, we have 1,000 active patients in our clinic right now. We have 8% on drugs. 8%, 92% without drugs, 92% with non-pharmacological treatment. So we are differentiating the patients determined on response patterns, and those that are really difficult to treat, like might be genetic disorders and stuff like that, we consider it, but they are still much too expensive to be realistic. So it is very, very pinpoint cases, you could call it. But I think they have a place, but not the place and an overall solution. They're just an add-on to something that, in our point of view, is less than 10% receiving them.
Yeah, and maybe let me add to that and to say that, of course, they have a place. They're a very nice tool, so we should use them. But that's the difference between individual medicine and public health. You cannot get every time to everyone. Innovation also does its place and its cycle, so I guess that you will have to analyze the cost for the system, how the systems can include it and give it to disseminate it to everyone. So I guess that's a role that has to be played. Just to say that it's a very idealistic idea to say that it's not a cost in an investment. It's going to be a cost for every ministry allocating the budget. And just to finish also with anecdotal evidence, which is a true story, the Japanese Ministry of Health a few years ago, we went to his Ministry of Finance, very happy, very saying we can have 15 million costs savings in this prevention initiative, and the finance minister was, okay, nice, so next year I'll give you less, 15 million. And that's how ministries work, and so that's what in the end will also cost in the decision.
I'm afraid our timer is ticking down, so we don't have time for any more questions. I wanted to give Andreas the final sort of word here before I wrap up. In a very quick sentence, if we were back here in 5 years talking about all of the sort of thinking about all the things we've discussed, what change would you like to have seen in obesity care if we're here in 5 years?
The answer is quite simple, that we don't have to meet here at all. Because obesity is being treated like any other disease. And there's no need for discussions like if they get it and how they get it and how to change the pathways, because everything is in place then.
Fantastic. A great rallying call to us all to finish with. So thank you very much to my panel. You've been fantastic. Thank you also, audience, for coming.